Good evening. Welcome. My name is Lauren Johnston, and I am the Program Officer for Rare Melanoma Subtypes with the Melanoma Research Foundation. It is so exciting to be here today during Pediatric Melanoma Awareness Month with one of our supporters, Dr. Vernon Sondak. The Melanoma Research Foundation is currently at the beginning of a month-long campaign to educate the larger public about pediatric melanoma. We will end the month with our annual Pediatric Summit, which will be virtual this year, the week of September 1st through the 25th. For those of you wondering, yes, kids can get diagnosed with melanoma, and our amazing speaker will be covering that tonight. I'd like to introduce Dr. Vernon Sondak, Chair of the Department of Cutaneous Oncology at the H. Lee Moffitt Cancer Center and Research Institute. Dr. Sondak has been a leader in studies of surgical treatment of melanoma and other cutaneous malignancies, particularly in the application of sentinel lymph node biopsy and lymph node dissection to the staging and treatment of melanoma. He has also been instrumental in training many surgical oncologists in these techniques over the years. Dr. Sondak has been a staunch supporter of the Melanoma Research Foundation, especially our pediatric melanoma program. It's so exciting to have him here and educating everyone on the topic of pediatric melanoma. So Dr. Sondak, thank you so much for being here. I just wanted to get started with a couple quick questions. The first one being, how long have you been with Moffitt Cancer Center and in pediatric oncology?
Okay, so I came to Moffitt in 2004. So that means I've been here about 16 and a half years.
And that's a long time. And how long have you been part of the MRF's pediatric program, would you say?
I would say pretty much since it began.
Which is exciting. You've seen us grow and change over the years, so it's awesome. You've just been so instrumental in our pediatric melanoma community, and I just want to say a huge thank you from everyone at the MRF, but especially our patient community for all that you do. And with that, I am going to let you take it away and explain what is pediatric melanoma.
Okay, thank you. And yes, it's great to be part of this Pediatric Awareness Month, and certainly pediatric melanoma needs a lot more awareness too. So let's see if we can get this going. And you tell me if my slides are working. I'm presenting this in conjunction with my colleague, Dr. Messina, a pathologist who helped prepare many of these slides, although she's not on the program today. Our goals for what we're going to talk about are to review what pediatric melanoma is and examine the similarities and differences with adult melanoma, and then to discuss a little bit about the treatment of melanoma and one specific, very related situation, the atypical Spitz tumors that occur in children. So what is pediatric melanoma? Really starts with the question of, when do you become an adult? Once you're an adult, you don't have pediatric melanoma anymore. Well, it's not quite that simple. Any melanoma that arose when you were a child, even if it continues when you're an adult, is pediatric melanoma. But when do you become an adult? Even both doctors, lawyers, anybody you want to ask, they don't always agree on what that answer is. Somewhere between 18 and 21, you go from being a child to being an adult for the purposes of the law, for the purposes of buying a drink, for the purposes of voting. All of those things have different definitions of when you get to be a grown-up. For the purposes of what is pediatric melanoma, I personally like to use 18 years old as the difference between adult and pediatric melanoma. We'll talk about a couple of the reasons why. One, of course, is that after age 18, most cases get sent to a grown-up doctor immediately. They don't usually go through a pediatric oncologist if they're over 18 almost anywhere in the country, adult doctors start taking patients at 18, and some take them younger. But many of the studies use 21, and I'll talk about the reason why we like 18 versus 21. The other big reason, the other big difference at age 18 is that a person can make their own decisions legally, sign their own consent form, and the clinical research trials that we're used to in melanoma and other cancers that help us make so many decisions, almost all of them start at age 18. So you don't have to be 21 to go on a research trial, but there are many studies that won't let you on if you're 17 and a half. And so for the purposes of studying pediatric melanoma, if it's 19 or 20, they go on to these adult clinical trials. But if they're 16, 17, 14, they often can't get on a trial. So 18 is the number that we use for saying anything below that is pediatric melanoma. But again, many studies use 21 or even other changes or deciding points in different situations. So this is an older study. They estimated that there were about 450 cases of melanoma diagnosed in children in the United States annually. I think that's an underestimate, especially if you use the 21-year-old cutoff. And of course, we know that since 2013, pediatric melanoma has steadily gone up. I think these numbers are more accurate, that pediatric melanoma is just a small minority of all cases of melanoma and just a small minority of all pediatric cancers. So let's look at this one, the percent of cases of melanoma. How many cases of melanoma are there in the United States each year? Well, currently there are over 100,000 cases of melanoma a year in this country. I think much more than that if we count all stages, including melanoma in situ. If you only count the invasive melanomas, the Cancer Society usually quotes in some number in the 70 to 80,000 range. Again, I think a slight underestimate, but if we said 1% of 70,000, that's a lot more than 450. 4% of 70,000 is way more than that. So I think there's a lot of these cases. I don't think we do a good job exactly defining how many cases of pediatric melanoma there are in the United States. We do a little bit better when we get to this important category, which we call AYA, adolescent and young adult cancers. That's arbitrarily defined. And again, you'll find different cutoffs. Some people say a young adult is 40 years old. Some people say it's 30 years old. This one said 15 to 29. But in adolescents and young adults, the melanoma is actually very, very common, not very rare. And once you get to about age 18, that's when we see the rate of melanoma really going up. And that's another reason why I use 18 as the cutoff, because when you include 18 to 21, there are so many more cases, it kind of loses some of the information about the younger children. Now, even though anyone can be a kid, anyone who is a kid with melanoma doesn't get the same kind of melanoma. There are different types of melanoma that are more common in the different age groups. In the slides that are going to come, I kind of break it down with fixed and arbitrary age breakdowns, but I wanted to show this slide because this really kind of shows a couple of things. One, that there are several different types of pediatric melanoma. And even though this isn't to scale, you see that one type that we call congenital starts really early and fades away very quickly. By the time, if somebody hasn't gotten it, by the time they're 2 or 3 years old, they won't get that type of melanoma. This other type gets more common as they get a little bit older, but by the time they get to adulthood is very rare. So rare that when we see a patient who's 25 or 30 and someone says, I think they've had a Spitz tumor, a spitznevis, we say, oh, wait a minute, are you sure this isn't just melanoma pretending to be something else? But what we also see here is that adult melanoma, some children who are diagnosed with melanoma today are people who in the past wouldn't have been found to have melanoma till they were 19 or 20 or 21. So if you can imagine that you had a melanoma that started when you were 14, but didn't get picked up till you were 20, versus a melanoma that started when you were 14 and got picked up when you were 15, earlier diagnosis is usually better. And so it's not surprising that we are doing better with children in melanoma than their young adult counterparts sometimes, because sometimes we're just catching it earlier. We're catching it earlier and not calling it adult, but it was never adult. It started when they were a child. It was pediatric melanoma all along. Nobody knew about it. Once we get past this graph at age 21, this curve goes way up through the roof, off the top of the chart here. So I don't even show it. But what this shows is that some pediatric melanoma is just melanoma that in the past used to not be diagnosed until the child had grown into adulthood. And as you see here, even though this isn't perfectly to scale, if you look at this yellow from 18 to 21, there's more yellow here than all the rest of the colors put together. So when we include every person from 18 to 21 in a melanoma study, we get dozens, if not hundreds of cases between 18 and 21, and only a few less than 18. So I like to focus exclusively on the under 18 group for that reason as well. So let's go sort of, not quite year by year, but group by group. And again, I say on this chart, it's kind of arbitrary between them. But if you remember that first chart, you remember it's not just boom, age 1, it all changes. But nonetheless, we're going to look at the different types of pediatric melanoma and break them down into categories. So life starts in the uterus, and then the child is born, and some melanoma happens in the uterus before the child is even born. That is truly congenital. The baby is born already with melanoma. When that happens, it is extremely rare, fortunately. Hasn't happened in this country, to my knowledge now, for about 7 or 8 years. But it happens because the mother had melanoma and it was spread to the child. Even rarer than that is that something happened to the unborn baby to get melanoma, so they developed it and got it when they were born, even though their mother never had melanoma. We know one young lady who's in that category, unfortunately doing quite well. That's one of the rarest things, one of the rarest kinds of cancer in all humanity, is to develop cancer, develop melanoma in yourself before you're born. Getting it from your mom is super rare, but it is a worry if young women of childbearing age get melanoma and it becomes widespread and they get pregnant, it can be transmitted to the unborn baby. The most common reason why very, very young children get melanoma is because they have a precursor lesion, some form of giant congenital nevus, which is the medical term for a birthmark, but not a regular birthmark, a giant birthmark, one that covers a significant part of their body. A special kind of birthmark that's at high risk of turning into melanoma is a neurocutaneous birthmark, meaning one that is both on the skin and going down into the brain or into the spinal cord. The most rare melanoma in this age group is the kind of melanoma that's the most common in other age groups. Melanoma that just starts on your skin where your skin was normal and grows as a dark spot. Anyway, here's one example. This is a neurocutaneous birthmark, one that's on the scalp, and you can see a big birthmark over almost half of the child's scalp. But what you can't see on the picture is the part that's growing internally. We have to do an X-ray or scan, like an MRI scan, to see that. The melanoma can start on the outside, can start on the inside. So this is a one example of the kind of melanoma that happens in very, very young children, almost always from some sort of very large birthmark. As giant congenital nevi go, this is a small giant one, okay? Like a jumbo shrimp, a small giant. I have children who have birthmarks that go from their neck down to their knees, and that's a really giant one. And the bigger the area of the birthmark, the greater the risk in the course of a lifetime, but also the sooner that they tend to get melanoma. So precursor lesions are the most common problem in this youngest age group. The next group or category we think about is childhood. For us, that's when they're no longer an infant, but before they've gone through puberty. Now, when we do a study, when we do research, when we look back at our records, our data, we don't often write down, oh, this is the day that so-and-so went through puberty. We don't always know what day it is. We're not we're not sure, has it really started, has it finished? So in our medical research, we'll often pick an arbitrary time frame. And currently, the average kid is getting into puberty by around 10 years of age, 10, 12. So between the time they're not an infant anymore and they're just starting to go through puberty, we call that childhood melanoma, as opposed to adolescent melanoma. Okay, it's terminology, it's semantics, but we use that to keep it straight. About 10%, 11% in this one study of a national database called the SEER database that keeps track of a lot of cancers of different types across the whole country, were in this pediatric, in this childhood group. So 11% in this study of all melanomas under 18 were in that 1 to 10 age range. It is different than adolescent melanoma, as I showed before in that slide. Remember the one with the 3 curves. The adolescent, the yellow, is just starting to take off. The blue, which is more typical of the childhood, is mostly in this area. There's overlap, but in general, they seem distinct. And we believe very strongly that the prognosis is better everything else being equal, when the melanoma arises during this childhood time than it is for the adolescents. It's not bad for the adolescents, but it's a little bit better for the childhood melanomas. And again, here is a graph, a real graph, not an artificial one like I showed earlier, showing how rapidly after age 10 or 12, the rate of melanoma goes up, whether it's girls or boys, whether it's in whites or blacks or others. It starts to go up after puberty, and it's much, much more common. And again, oops, went the wrong way. Want to illustrate that point about, look at how different there it is between 18 and 20. Look at how it's really skyrocketing at age between 18 and 21. So if you include all of these cases, you learn, you kind of swamp the younger cases. So the message I'm trying to make without having anybody memorize numbers is that when you can look at a curve like this and say, oh, melanoma is not a problem until you get older. But what you miss when you do that is that there are different categories in here, and you really have to tease it apart. And that's been very important to us as we study and learn about melanoma in children. So let's look at some other things that we know about melanoma in all pediatric patients across the spectrum of childhood, across all melanomas up to age 18, there is a slight female predominance. Some of this is driven by teenagers we see in teenage girls, a higher use of tanning beds, more going out in the sun and trying to get a tan. We see in teenage boys, they don't necessarily pay attention to putting on sunscreen, but they don't do as much intentional tanning, recreational tanning, as we see in teenage girls. So there's a slight female predominance. About 85% of melanomas under 18 are in whites. Well, that sounds like a lot, but if you talk about adults, 99% of adult melanoma in the United States is in white individuals. Only 1% is in darker skinned individuals, Hispanics, blacks, etc. So at 85%, there are many more non-whites with pediatric melanoma than there are in adults. And this kind of breaks it down by where do they occur. Well, we've seen patterns there too, that melanoma on the trunk, the chest or abdomen is more frequent in older children, legs, head, neck, more frequent in younger children, arms and legs and head and neck. Girls have a higher incidence of leg melanomas, and boys have a higher incidence of head and neck. But these are small differences, vague generalities. We would never say that this is a strong trend of any sort. Here are some things that are more strong trends, more characteristic of pediatric melanoma, especially childhood melanoma. The conventional ABCDs we often hear about. Remember your ABCDs to know if a mole is melanoma or not. We've recognized for years that the younger the child, the more likely that those ABCDs won't be characteristic of their melanoma. Here's a picture of a pediatric melanoma, a very young child. First thing you see is that the skin is way darker than this melanoma. This is one of those 15% of non-white patients who still developed a melanoma. It's frequently amelanotic. What does that mean? It means that the melanin pigment that gives the skin this black or dark color is absent in the melanoma. Most adult melanomas are melanotic. That's where the name melanoma came from. That's why they are dark brown or black, because of that melanin, that melanotic character. This melanoma, except for that small spot right over there, is completely absent with pigment. It's got the reddish color of the blood that's in it. There is no, it's not skin color, it's not flesh color. It's actually got no color at all except for that one little area, other than the blood that's coursing through it. Because of a lesion like this is easily mistaken for something else. It's very nodular. It looks like a nodule, and it's easily mistaken. This one, not so much for a wart. If it had more stripes and um, and kind of lines within it, pediatricians say, "Oh, you got a wart there." In this case, they'd say, "No, it doesn't look like a wart. It's not warty enough, but it must be a pyogenic granuloma." That's a little skin infection that creates a little nodule. And many pediatricians would just say, "Oh, that's nothing. That's just a little pyogenic granuloma. Don't worry about it." Unfortunately, it wasn't nothing. It was something to worry about. Because it's nodular, because it grows this way, and because often people say, "Don't worry about it. It's just a kid. You're not even a child with the right skin color to get melanoma." It often doesn't get picked up right away. And it's so common that we see that pediatric melanoma is thicker when it's diagnosed than in adults. Fortunately, that thickness disadvantage doesn't translate into a worse outcome. The survival is actually still better despite that thickness disadvantage, if you will. And then there are the special skin tumors that seem to only be or characteristically be in childhood. These are the skin tumors that look like or are spitznevi. What's a spitznevis? It's a special kind of mole that was recognized many years ago in the 1940s, as a matter of fact, by a dermatologist named Sophie Spitz. She was one of the first female dermatologists in the United States. It wasn't always easy for a doctor, for a woman to become a doctor of any sort, including a dermatologist. But Sophie Spitz was one of the best, and she said, "People are calling me up and saying these children have melanoma." And she studied it and said, "No, this is a benign mole." And in later years, they named it after her and called it a spitznevis. But then people realized that there are some melanomas that look just like a spitznevis, and we call these spitzoid melanomas. And in between are some moles that are really difficult to tell, and the pathologists can't agree. That's what we call in the medical terminology, lack of inter-observer concordance. It means two pathologists are yelling at each other and going, "No, you dummy, that's not a melanoma, that's a spitznevis." And the other one is saying, "No, it's not, it's a spitzoid melanoma." And they can't agree. And not only that, sometimes their reports are so complicated, we can't even tell, well, which one do you think it is? Do you think it's a spitznevis? Do you think it's a melanoma? You have no idea. You're writing, the longer the report, we often say, the harder it is to tell what's going on. In recent years, molecular testing, fingerprinting, I call it, such as FISH and CGH, can be helpful. Sometimes can say, "Whoa, this is definitely not benign," but often they just kind of give us some shades of gray. They don't give us a black and white answer. So here at Moffitt, my colleague, Dr. Messina, developed a unique 5-point grading system. It doesn't tell the pathologist what it is. It tells the doctor what the pathologist is saying it is, and it communicates the pathologist's level of certainty that a specific tumor is benign or malignant. So we'll see how that works here in a moment. This is that 5-step process. If our pathologist is completely sure this is a benign, in this case, spitznevis, they can just write down S1, and we know that they are telling us that they're looking at it under the microscope. They don't see a single feature that could possibly indicate that this could be cancerous. At the other end of the scale, if they say S5, the pathologist, Dr. Messina or whoever it might be, is telling me this is melanoma. It might look like a spitznevis to you. It might have some characteristics of a spitznevis in its individual cells, but it's a melanoma. I don't have any doubt about that. How do they make this assessment? At our center, we strive to make sure they have all the information. What did it look like? How quickly did it grow? Not just look at it under the microscope, put the whole picture together. We think that's very, very important. We know that many times these moles that are difficult get the pathologist isn't sure, so he puts it in an envelope and sends it off to San Francisco or Boston or Texas or Florida. Says, here, tell me what this is. Look at it under the microscope and tell me what this is. Well, here in Florida, we say we can't just tell you what it is. We need to know all the information. We can do a better job of telling you what this is if we have all the information about the mole, and that's something we place great importance on. If we have any doubt, we do additional testing, both immunohistochemical testing. I'll show you some pretty pictures of what that looks like, and molecular testing if necessary. And another thing that's important about this 5-point scale is it changes sometimes. We might start out, I'm not really sure, just hearing your story, looking at it under the microscope, I'm not sure. I'm right in the middle here, right halfway between benign and malignant. But maybe I'll do some tests. You know, these kind of worry me. Now I'm a number 4. You better operate on this person. And then you send me more tissue, and the pathologist says, whoa, now I see this. This is clearly malignant. So all important points that this is not a ironclad, oh, you don't have to worry about it. This is a communication scale, and it's a scale that is fluid, that can change, and you can use more information to get a better and better and better assessment. And that's what we try to do. And here is that scale with some actual pictures of what these things look like under the microscope. That is a picture of under S1 of what Sophie Spitz originally called spitznevis. And each different picture gets a little further away from that perfectly normal, benign spitznevis to here, where a pathologist can recognize that this has similarities to that one. They can say, oh, you see this part right here? That looks like that part over here. But most of us go, that doesn't look anything like that. But to the pathologist, there's some continuity between each of these, but at each level, they get more and more and more convinced or concerned until they're finally convinced that it's really melanoma. Now, what's important to me is I want to know where they fall on the scale, but even at level 3, if the pathologist isn't sure that it is benign, we're going to take care of the worst case scenario. We're going to make sure we've taken more tumor out, more out, a re-excision, send that to the pathologist. And most of the time, we're going to do a sentinel lymph node biopsy to make sure it hasn't spread to the lymph node. So in the next few minutes, I'm going to talk about the different kinds of treatment and show some pictures of surgery, as they like to show on the news. They say, so caution, some of these pictures may be graphic. When they do that on the news, everybody runs to the TV, say, oh, I want to see that. What are they saying? So you decide if you want to see the picture. These are grown-up pictures, not children, but nonetheless, here's a melanoma, a nodular melanoma that we're going to remove. And we actually measure this. When we do an excision, we measure a distance around that melanoma to decide how far and how wide to excise it. We also inject, this is a different melanoma, but you see it again. We inject this blue dye right at the edge of the melanoma to help us find the sentinel lymph node, the lymph node that is connected to that piece of skin. And sure enough, there almost always is one. And that blue dye traveled under the skin in a lymphatic channel and ended up in this little lima bean shaped reddish lymph node that the injection we made way over there is causing to turn blue way over here. And then we find that lymph node and we take it out and we send it to the pathologist, and we've drawn some little dots on it to show the pathologist where the blue areas were, where we're worried about, where we want them to analyze. That is an actual lymph node. As you can see, in this case, it's not even half an inch in size. Now this half an inch is gigantic compared to what we look at under the microscope and what we're looking for with our melanoma. Tiny, tiny areas. If you could imagine that whole lymph node was half an inch, and this is a tiny portion of that lymph node looked at under the microscope, and in that lymph node, there is a tiny area of melanoma that was detected by these special immunochemical stains. The normal benign lymph node cells are blue, the melanoma stains black, or if we use a different stain, red, and stands out to the pathologist. Sometimes it stands out so that you can see individual cancer cells. Here's a different part of the lymph node with a different red stain. You can see, oh my goodness, 1, 2, 3, 4, 5, 6. You can count the individual melanoma cells. That's how powerful this sentinel node biopsy test can be for finding individual cancers and letting us know that, yes, this really is cancer. All right, so we do that and it is in the lymph node. What do we do about it? Well, melanoma treatment has been changing so rapidly, and that impacts both adults and children. And nothing has changed more in recent years than the treatment of the positive lymph node situation. In the past, I always tell my patients, in the old days, 3 years ago, we would have taken out all your lymph nodes. The next step was surgery, take them all out. One lymph node under the armpit is bad, take all the lymph nodes out under the armpit. That worked pretty well, but if we do take out all the lymph nodes, it causes a lot more long-term problems or a tendency for problems than just removing that one small little half-inch lymph node causes. And most of the time, we don't find anything in those other lymph nodes that we removed. So we asked the question, how much does it really help? And when we did studies in adults, not in kids, but in adults, we found that, you know what? It sure didn't help very much. It was okay to observe the patient who had a positive node as long as we were very careful and they always came back. But we still try to keep the melanoma from recurring, from returning. In the old days, again, a few years ago, we used a lot of interferon in our children, and it worked pretty well, but it's no longer used for adults at all. In fact, it's hard to even buy anymore because the drug companies don't want to make it. There's nobody really using it. Coronavirus might change that, but the reason we don't use it in adults is because newer drugs are available and they've been proven highly effective in preventing recurrence in adults with less side effects in many cases than we used to see with interferon. These drugs haven't yet been proven in children, but we're using them very widely. And there are two categories of drugs we use to try to prevent recurrence. After surgery, if the lymph nodes are positive, we don't use these if the lymph nodes are negative. Immunotherapy, immune stimulating treatment with anti-PD-1 antibodies, pembrolizumab or nivolumab. They're getting so common you can hear them advertised on TV, but not for pediatric melanoma. Pembrolizumab is the drug Jimmy Carter got for his melanoma, not pediatric. He was 91 when he got his pembrolizumab treatment and seemed to work for him. He's 96 right now, I believe. The other category is targeted therapy with BRAF/MEK inhibitors, usually the combination of drugs dabrafenib and trametinib, but that can only be used if the tumor has a BRAF mutation, a very specific mutation that these drugs target. In adults, just under half of adults have a BRAF mutation. In children, much higher percentage of pediatric melanoma has a BRAF mutation, not 100%, but much more than 45%. In adults, in part because of the numbers game and in part because of the perception that maybe if we stimulate the immune system, it'll be a more strong and durable response. Immunotherapy is the most common adjuvant treatment by far. But in children, we tend to use more of the targeted therapy, A, because the mutations are more common, and B, because there are fewer long-term side effects. The side effects are higher while you're taking the drug, but there's less chance of those side effects being lasting side effects once the drugs are stopped after a year or after side effects develop. If they have to be stopped early, the child usually quickly goes back to normal. So many of my pediatric oncology colleagues prefer to use the inhibitors than the antibodies if they possibly can. And these inhibitors are also pills. That's nice for kids too, no injections or infusions. But no proof that one is better than the other. What these definitely are trying to do is kick the can down the road, make it so that it doesn't come back, or if it does come back, the child is older, often an adult already, and has more treatment options and more ability to be treated. And that brings me to my last and kind of an important point about pediatric melanoma. I made it at the start, but I want to remind people that it's pediatric melanoma if it's developed when you were a child, even if it comes back when you're a grown-up. And in fact, many times we do surgery on a 13 or a 14 or a 15-year-old, and it doesn't come back for 5 or 6 or 7 years. That's what this graph is showing us, that most of the recurrences or deaths, over half the melanoma-related deaths occurred after 5 years after the surgery. So if they were 14 when they started, they're 19 when it comes back. That makes them a grown-up in the eyes of the doctor, but it's still pediatric melanoma, and we still have to keep that in mind. So I'm going to conclude now that there's a higher rate of positive lymph nodes and it's thicker. There's a lot of things about pediatric melanoma that seem like they should be worse compared with adults, but yet the sentinel node still tells us what's going on. It's still correlated with the thickness of the tumor. It still helps us decide which children are at higher risk. But despite this higher incidence of nodal metastasis, the survival for pediatric melanoma is better than what's reported for adults with melanoma, certainly in our hands, and even better if the melanoma was diagnosed before puberty. But the bad news, recurrences and even deaths are seen beyond 5 years, so long-term follow-up is very, very necessary. And that can be a challenge with younger children. It can be a challenge with adolescents. It can be a big challenge with young adults. They go off to college, they move to a different state, they get married, they change their name, they have kids of their own. Follow-up gets harder and harder as kids grow, but it's very, very important. So I'm going to close. This is my colleague, Dr. Messina, who did a lot of the work and made a lot of these slides. And this is my boss, that is H. Lee Moffitt himself, who Moffitt Cancer Center is named after, and he's still around, and we see him quite frequently. And this is us at a big event we had to raise awareness about pediatric melanoma a few years ago. So with that, I'm going to thank Lauren and everybody at MRF for giving me a chance to talk to you guys about that and maybe answer a few questions.
Thank you so much, Dr. Sondak. That was informative for me, and I'm immersed in it, so I really greatly appreciate it. And I did divert my eyes from the pictures, so just letting you know they were wonderful. We do have a couple of questions. One came in during your session, and I know that we're talking mostly about cutaneous melanoma in children, but this one was asking how common is ocular melanoma in children?
So yes, I was talking mostly about pediatric skin melanomas. Other sites of melanoma occur in children and in adults. I have several patients who got ocular melanoma in their late teens, 17, 16. I don't personally know of any kids much younger than that. There's no reason it couldn't happen, and I'm sure there are some cases, but ocular melanoma is much less common than skin melanoma in general. Probably maybe 1 for every 20 to 40 skin melanomas, 1 to 20 to 40 skin melanomas in adults, and probably at least that, if not more, in kids. So, but it does occur, it can happen, but it is tends to be older kids, and even then very, very uncommon, even by pediatric melanoma standards.
Okay, thank you. So I know that the Melanoma Research Foundation is really big on skin checks. We really encourage our adults to go get them every year, and then we've really started to push for our pediatric patients to go as well. If a parent does see something and they take their child to a dermatologist, what kind of questions should they ask regarding this this thing that they might see, like a spot, or like you said, like maybe something that looks like a wart? What would you encourage them to do?
So the first message I would have is that in general, mom knows the kid's skin better than anybody else. And it's very, very commonplace that mom starts with a pediatrician rather than a dermatologist. And the pediatricians tend to think, like I said, oh, it's a wart. Oh, it's a pyogenic granuloma. That can't be cancer. They're just a kid. If it's not right, say something. If the doc says, I think it's just a wart, try this treatment. I think it's just a pyogenic granuloma. We're going to give you a few antibiotics for a while. Fine, because most of the time they're going to be right. But if it's not getting better, if it's getting worse, Don't say, well, he said it was nothing. She told me it was fine. No, stand your ground and say, hey, this isn't getting better. I want a biopsy. I want a diagnosis. I want to know what's going on. Ask to see a dermatologist. If you go to the dermatologist, it's a little bit the opposite. The pediatricians say, oh, we never biopsy anything. Dermatologists are used to biopsying everything. Probably we want somebody who's right in the middle. We want to be able to say, biopsy the things that need to be biopsied, watch things, but if they're not getting better, if they're getting worse, they got to get taken care of, because those other things that it's supposed to be, like a wart or a pyogenic granuloma, they should get better. And if they don't, they need to get biopsied. I would tell anybody, grown-ups or kids, go to the doctor. If you go to the dermatologist and they say, I want to do a biopsy, ask them and say, why? What do you think it is? How are you going to do the biopsy? Are we going to sew it up? Are we going to numb them up? It's hard enough to go through some of those biopsies as a grown-up. A kid, it can be pretty traumatic, and make sure you understand what are we going to do. And one thing that can be really helpful, make sure if you're taking your kid to the doctor for a lesion, take a picture of it. Take some photos, especially if it's been changing. That can help. We recently had a case. One of the children I just operated on a few weeks ago, the mom's pictures showing the change immediately convinced us that it was melanoma, when in San Francisco, they were testing him and going back and forth. And I'm not sure. Said if you saw picture A and picture B, you wouldn't have to run any of those tests. You'd know that this was melanoma. And sure enough, that's what it proved to be. So a picture can be really helpful. Many dermatologists will take a picture before they take the biopsy, and then I can call them up and get a copy of that picture. But with today's cell phone technology, anybody can take a picture of it. So if you're taking your kid in to get checked, great idea to get a few pictures of it for the record.
We had a adult ask a question that they've had invasive melanoma and want to know how likely would their children also have melanoma or develop melanoma later on.
So in the course of a lifetime, if mom had melanoma, it's not unusual that in the course of a lifetime, their children are going to possibly get melanoma. Why? Because chances are mom or dad had light skin, red hair, lots of funny looking moles, out in the sun a lot, the whole family tends to live in the same state. And if it's Florida, they're getting exposed to a lot of sunshine. A lot of common factors, not genes necessarily, but factors that run in the family, that everyone shares in the family. So it's not unusual that more than one person in the family gets melanoma. What we have found is very unusual, actually, for our young children for us to have any strong history of melanoma in the family or any genetic predisposition to melanoma. There's something going on, but it's not that, oh, everyone in my family's had melanoma and now my kid has it. That doesn't seem to be a common thing that we see. But if you have melanoma, you need to protect your children from the sun so that when they grow up, they don't get melanoma.
Wonderful. And then in regards to all of the treatments that you were talking about to treat melanoma in the younger children, are any of those leading to possible secondary cancers that parents should be aware of as their kid gets older? What should they look for in that?
Great question. Big concern with pediatric oncology in general are late effects. Most of the treatments we use for melanoma, fortunately, don't have late effects. But immune stimulating treatments stimulate an immune response against the cancer, but they can also stimulate an immune response against the normal parts of the body. So one of the reasons we sometimes, if we have a choice to use the pills or the immune intravenous antibodies, we might use the pills, is we don't want to stir up an immune response that leads to hormonal problems, diabetes, endocrine problems, or even heart problems that are very, very rare, but they occur in a small percentage of cases. And if that happened to a child, it can be a lifelong problem. So we use immune therapy in children, we use it safely, but if we have a choice, we sometimes don't start with it. Mostly we're not worried about second cancers, we're more worried about these chronic things.
Okay. And I know you had mentioned recurrence as well for the older age group. Is that, so you're strongly encouraging continuing surveillance into that older age group then? If
Yes,
you had
correct. Absolutely.
Okay.
One of the many reasons why they should keep being checked.
Wonderful. Well, I just wanted to say thank you. We're about out of time. This has been a wonderful kickoff for our Pediatric Melanoma Awareness Month. And for people who are watching, Dr. Sondak will be having some additional webinars for our Pediatric Summit. That is the week of September 21st through the 25th, and registration is open. We are just super thrilled, again, Dr. Sondak, that you spent your evening with us. Thank you so much, and for being willing to just educate the larger community about this rare disease. We just can't even thank you enough and show our appreciation.
Happy to help out.
Wonderful. Well, have a wonderful evening.
All right.